Hey everyone, how you guys doing? So we're about to hop into our next panel, which is our sports medicine panel. And it'll be moderated by Francis Shin, the Associate Professor for the Law of University of Minnesota. He directs the Shin Neuro Law Lab and leads the Grand Challenges Grant on youth sports concussions. Dr. Stewart, Professor of Orthopedic Surgery and Chair of the Division of Sports Medicine at Mayo Clinic. Dr. Lukowski, Co-Director of the Mayo Clinic Sports Medicine and the Professor of the Department of Physical Medicine and Rehabilitation. Amy Custard, she is a clinical neuropsychologist and now is announced as the Clinical Director for TRIA Sports Medicine. And then Amy Hamilton, she is the manager of TRIA Sports Medicine Program as well as TRIA Concussion Program. Thank you.
Great. Well, thank you, Tyree, for the introduction. Thanks to all of you for being here and Players Health for having this. My name is Francis Chen. I'm a law professor, but I study the intersection of neuroscience and law. And I'm just here to moderate, but I want to say a few words of context, both data and law. And actually this morning there was an op-ed by me in the Tribune, and I'll repeat just a minute of that. First on the data side, and to pick up on what was just said, there are a lot of risks, and we'll talk about some of those. There are a lot of benefits that have come with many sports, including football. And we have some data that show that, in fact, there's overestimation of the risk, maybe by a scale of 5. Same way people overestimate sometimes how much crime there is because they see a few headlines. The actual data on incidents and the public perception, there may be a difference there, though, again, lots of risks we'll talk about. Second thing that I wanted to say just a couple words on is the legal context. There are a lot of reasons we do things. And in sports, sometimes we do things because it's the right thing or we want to. Sometimes we do so because the law says we have to. In all 50 states, including Minnesota, have passed a youth sports concussion law. Our state's law looks like most of the rest, and there's a before, during, and after. The before part says that you got to give athletes and parents, coaches too, information about concussions and some regulations about what that info looks like. Also, before, you have to train, and we just heard about that, your coaches and your officials so that they're certified. That's the before. The during is that if you are a coach or official and you see symptoms of sign or suspect a concussion of an athlete, you need to remove them from play. And then there's the after that suspicion that if indeed they are removed for concussion, you need to go through a protocol. Here in Minnesota, it requires seeing a certain expert and then getting in writing permission to return. Now, here's the thing that I want to quiz you on. I'm a professor, so I have to ask this question. I will tell you that most of the public gets it wrong, but we'll see if you can get it right. The description that I just described, that before, during, and after, here are your 3 choices. Is that required of all schools and all youth organizations? Is that required for schools but recommended for youth organizations? Or is that recommended for schools and just recommended for youth organizations? Now, I don't have a way to check what your answer is, but you can decide what you think the answer is. Most people think the answer is the middle, that it's required for schools, but if you're a youth organization, you don't have to do all that. And it varies state to state, but here in Minnesota, the answer is A. If you are a municipality, an organization, you run an athletic activity and you charge a fee for it, it's kind of the way our law is phrased, you're required to do those things. Now, the challenge of the law is that you receive no resources to do it, and it specifically said at the end, you don't have to worry so much about liability because it says no new legal cause of action is created. That is, if you don't do it, you don't do it. And no one can sue you for not doing it, though it does raise questions about the reasonable standard of care. But I just want to make that point that when you go back, if you're an administrator in your league, not only should you say, maybe we ought to do it, the law requires you to do it, even if there's not an enforcement mechanism. So that's the law. And that leaves, I think, a transition into where we go next, which is, what should you be doing before, during, and after? What are the best practices? And we have with us 4 of really the nation's best, and certainly here in our state, just leading experts from a variety of perspectives. You'll hear that, and I think one of the themes you'll hear is how in different professions they work together to try and come to diagnoses and consensus. We'll start with Dr. Lukowski, who will talk about injury prevention generally. Concussion is one, but not the only and not the most common injury in sports, and we'll then move into some concussion-specific issues. But Mal, hand the floor over to you.
Thanks, Francis. Yeah, you're absolutely right. About 85% of sports injuries are musculoskeletal injuries. They're injuries to the joints and muscles and tissues. So those are what we handle the most. And just tagging off of what we heard earlier, a couple things. We want to keep kids active. We want to keep kids out there. We have an epidemic in this country. I've served on 2 president's councils on physical fitness. 70% of our kids overweight, obese, sedentary lifestyle. So we want to get kids moving. We want to keep them out there. Just a couple of resources, again, building on earlier discussions. Project Play, if you just search Project Play, this is a group by the American College of Sports Medicine, the Robert Wood Johnson Foundation, the Clinton Foundation. The whole goal of that is to get kids moving, get kids back into free play, get kids active. A lot of coaching character is built into this program. It's just a wonderful program, and it's taking off. Some of those figures that you heard earlier, that's where the survey came from, where 43%, number 43 was winning. Number 1 and 2 was having fun and being with friends, is what kids want to do out of activity and sports. So that's a great resource. And then the Inside Out initiative is something that I just heard, actually, that is incorporated into some of the Minnesota State High School League, but it's a wonderful group. If you just search Inside Out initiative, they're about character building. So we want to keep kids out there. We want to keep them. We can't prevent all sports injuries. What we try and say, Dr. Stewart and I, we do sports medicine, so we deal with these injuries. What we try and do is protect somebody as much as possible. And what we found out is the way you move in many ways determines your risk of injury. So if you come into Mayo Clinic Sports Medicine in downtown Minneapolis, across from Target Center, you'll find a huge turf area. We have a 40-yard turf area, but we also have cages that come down, and we have a ton of cameras. So we use a lot of video. So we have a 60-foot, 6-inch cage if you're an overhead thrower that you can throw in. We have a golf swing cage. We have a runner's treadmill that's videoed. In Rochester, we actually have artificial ice and a skating treadmill. All these are monitored by cameras, and our therapists and performance coaches work with the individual who is being tested, and we look at video analysis. Because we found that the way you move is very important. You may have heard the phrase, practice makes perfect. Is that true? It's perfect practice that makes perfect, right? So if I'm a tennis player and I swing badly in a backhand, right, and I lead with my elbow and I slap the ball like this, I'm going to overload this tendon here that goes on the outside of my elbow. It's called lateral epicondylitis, or tennis elbow. So I can do all the therapy I want in here. Dr. Stewart can do all the surgery he wants in here. If that person goes back to slapping at a ball like that, they're going to have the problem over and over and over again. So we really have to find out what is the movement problem that led to that issue. We're finding ACL injuries are epidemic, as you guys know, especially in females. And one of our researchers, Dr. Tim Hewitt, along with some others, have found certain movement patterns that are risk factors for ACL. Very simple test we can do. Actually, a single leg stand. If you do a single leg squat, the knee should go right over the foot on the way down. What we have found is this position we call dynamic medial knee valgus, where if we ask somebody to do a single leg squat, their knee caves in. Or if they land from a jump and they cave in, that's bad. And we found it's a predisposing factor to ACL injuries and a whole mess of other problems too. If you're a runner and you get ITB syndrome on the outside of the knee, chances are you have that movement pattern. If you have hip bursitis, chances are you have that movement pattern. If you have sportsman's hernia even, chances are you have that movement pattern. So those are things that we, in our pre-part exams, we actually screen for those. And if somebody exhibits in a single leg squat that inward movement of the knee, we'll actually send a letter home saying, hey, good idea, this has been associated with injury, good idea if you come back and correct that. And we have a corrective program of exercise that we can do for that. Same thing with the throwers. You can imagine an overhead thrower. There's something called opening up too early, which you guys probably know about. If you face the plate too early, you throw all that energy back into the ground that you generated with your legs and core. And all of a sudden now this shoulder has to generate 90 miles an hour and 100 miles an hour. No matter how young, no matter how strong you are, that's going to fail over time. So the movement pattern of a perfect baseball throw, you look at the greats, Nolan Ryan, 46 years old, pitching 95-mile-an-hour fastballs. He is a clinic on how to pitch. Guy's got glutes, huge glutes. He transferred his force from his legs to his core. This was just a passenger along for the ride. It was not a prime mover. When it becomes a prime mover, it breaks down over time. So those are things we try and tease out, and there are movement patterns like for the knee we've identified, that inward movement of the knee. There are mechanics factors in just about every sport movement that you do that we can, when we video, we see how you're doing it, and maybe there's some specific restriction. Maybe you have a tight hip muscle and you're a golfer, and it's preventing you from kind of doing the necessary rotations. So all of a sudden you're getting back pain and shoulder pain. Well, again, we can address this shoulder all we want. If we don't fix that hip issue, we're not going to fix the problem. So the way you move is very important, and we analyze it. We try and give corrective steps to correct the bad movement patterns and get you in the most optimal movement pattern for your sport or activity.
Great, thank you. We'll move next to Amy Hamilton, you've heard introduced. I'll add also past president of the Minnesota Athletic Trainers Association, so it's got an institutional and organizational perspective as well, and will talk to us about concussion from the sideline and then treatment afterwards.
All right, so I'm going to bring the athletic trainer's perspective. So my first question is, do you have an athletic trainer? And you're going to say, oh, she's biased, she is an athletic trainer, and that might be a little bit true, but hear me out. So I'm going to tell you the why. So first of all, we just heard a lot about prevention, and an athletic trainer, one of the pillars of our education is certainly prevention. And all of the movement screening that you just talked about, you know, that is a role that we very frequently play and are experts in, so we can certainly add to that. I think when you're looking at any institutional changes, rule changes, equipment changes, those types of things, to have an athletic trainer as part of the team that's looking at those things is really important. We bring a unique perspective, that front of the sideline type of perspective to that. Another element is, do you have an emergency action plan? We've heard a little bit about this, but that's critical. And this is something that should be written, it should be rehearsed ahead of time. A good emergency action plan and well-trained people will save lives. So that's critical. The other thing we've heard a lot about is, do you have a concussion protocol in place? So as I transition more into talking on the concussion side of things, do you have a concussion protocol in place for your organization? Another element that certainly wouldn't be only the athletic trainers, but we can certainly lend a huge hand in, would be that of education. We just heard Francis talk about education and how the law mandates that you have education. And we all believe, or want to believe, that certainly the coaches are adhering to their mandate to do their online CDC training every 3 years. We hope that that's certainly the case. In my experience with youth sport, I'm not seeing very many instances where that's being enforced with the athletes and the parents themselves. You know, at the NCAA level, at professional sports, that's a requirement. Those student athletes or the professional athletes, they're getting that education now as a mandate annually. We're not seeing that trickle down and really being mandated. And that's a critical element, is understanding a concussion, recognizing a concussion, and knowing that they need to report those symptoms and that they really have an obligation to report those symptoms. So when you think about from the sideline perspective, we know that the law states that if anyone exhibits signs or symptoms of concussion, they should be removed from play and evaluated by a medical professional trained in the management of concussion. Well, wouldn't it be great if that professional was right there on your sideline? So if you think about it from a perspective of, as an athletic trainer, if I see the injury occur, I'm there right away when it happens. I do an early evaluation on that injury itself. I know the early signs and symptoms. I'm witnessing them, I'm experiencing them. That plays into what's our treatment plan for this particular person. The other big thing about that early evaluation and giving good advice is giving good advice. So we all know that, and it is still the gold standard, that relative physical and cognitive rest is best early on. But what does relative mean? Some kids may not be able to go to school after a concussion, but for some kids it might be okay. They might do just fine. Some kids maybe need to eliminate all screen time. Other kids might do okay to have a little bit of screen time or to be able to do a little bit of reading. And to understand early signs and symptoms and to have good instruction on what this person might be able to try to do and what that recovery looks like can be very helpful in their overall recovery, and certainly as we are potentially passing them on to other providers, to give that early history and to know that they have maybe taken some good early steps, appropriate amounts of rest, maybe not too much rest in some cases. So beyond that, there's the element of follow-up care. So if you look at this from a standpoint of a member of the sports medicine team, to have somebody who is there on a regular, if not daily basis, who can follow up with that athlete or that student athlete, connecting the dots between the other medical providers and specialists who are part of that care team, the physicians, the neuropsychologists, the physical therapists, also connecting dots with parents and coaches and school nurses and guidance counselors, making sure that the return to learn and the return to play process is simultaneous and seamless. That can be a critical element. And then certainly last but not least would be the return to play, monitoring that return to play. I don't know how many of you experience this, but I've certainly seen a lot of examples where you'll have Johnny come back and he has his note from his physician that says Johnny's cleared to play. But if Johnny hasn't done any form of a stepwise return, that means Johnny's returned to start a stepwise. And coaches don't like to hear that, right? And so there's that element of having that supervised stepwise return to play. And someone who's there on site who not only can supervise that, know that it's happening, know that the steps are taking, but also make sure that the levels of exertion that should be met at each step to know that they're really truly ready to go on to the next step. That's a critical piece as well with regard to recovery and knowing that we're sending someone back safely. And I'm probably out of time, but I'm going to make one more plug.
You're good.
The other element is a financial one. So if you think about cost to families, one of the biggest things, you can mitigate cost to families by having medical providers on your sidelines. You can eliminate some needless ED visits, some needless urgent care visits. You have the follow-up care or a piece of the follow-up care that may be included there when you've got that person associated with your team. And certainly there's an element often of being able to get somebody to the right provider in a timely manner. If you start with the emergency room, if you start with urgent care, you might then get referred to your primary care provider. But if what you need is a surgeon or a neuropsychologist who's a specialist in concussion, we could help you get to that specialist immediately, saving some needless visits and saving money along the way.
Thanks, Amy. That's fantastic. We'll turn now to Dr. Michael Stewart, who in addition to his roles at Mayo that were announced, is the Chief Medical Officer for USA Hockey and has also served an important role on the Minnesota State High School League Sports Medicine Advisory Committee. So it's really, and of course, as again, many of you know, a parent of a high-achieving athlete. So multiple perspectives, a lot of knowledge, and we'll turn it over to you I know the constraint of a small amount of minutes, but tell us what we need to know.
Thanks, Francis, and thanks to Players Health. I'll try to be brief. So I appreciate everybody's attention. I want to talk first about injury epidemiology research. We need to understand what types of injuries occur in what sports, to which athletes, how they happen, how severe they are, how we can prevent them, and how we can treat them. But it's a real challenge, especially in youth sports. We don't have a national injury registry. We don't have national health insurance like Sweden. So every athlete has an electronic medical record entry that we can access. So we have to do cohort research and continue to strive to have this type of national injury registry. When we have valuable data, we can help prevent, diagnose, and treat sports injuries better. An example, we did a 3-year study, prospective analysis, on junior A hockey in the United States Hockey League, and proved that you are 25 times more likely to be injured in a game compared to practice. So when parents ask me, how can we reduce the risk of injury in sport? I tell them, never play a game. But they're not real happy about that, so we have to come up with other strategies. But I think sports epidemiology is very important. And we talk about concussion, and the role of athletic trainers is huge, as Amy said, but it's a multifactorial approach. So everybody has the holy grail, a helmet, a mouthpiece, a rule change, but it's much more than that. It's multifactorial. It starts with education, parents, coaches, officials, athletes, healthcare providers. It also involves things like equipment, but maybe more important is movement and body control and contact skills that Dr. Laskowski talked about. Teaching athletes how to block, tackle, body check, making sure that it's the appropriate age. That's why we look at rule changes. USA Hockey made a rule change to disallow body checking in games until age 13. Research out of Calgary has shown a 67% reduction in the risk of concussion to Pee Wee hockey players in Canada since they made that same rule change 2 years after we did. Enforcing the existing rules. We know from NHL data and from some of our own research, dangerous activities increase the risk of catastrophic and non-catastrophic injuries. In 1975, they outlawed spearing in football, saw a dramatic decrease in cervical spine injury and quadriplegia. Same thing in hockey. We understand that charging, boarding, checking from behind, and hits to the head are dangerous. One way to try to decrease that type of activity is to enforce the existing rules. Another way to do it, which is near and dear to my heart, but a tremendous challenge to all of us, is teaching sportsmanship and mutual respect. It was brought up here today. It starts at home by parents. It's not about professionalism and super specialization at the age of 8. It's about having fun, playing the game with integrity, having respect for your opponent. So we like to think that a good coach sees a player doing something potentially dangerous, and regardless if a penalty is called, take that player off the ice, off the field, off the court, and play that role of a teacher and explain about these dangerous activities. And I'll close with saying that even though there's inherent risk, like Dr. Laskowski said, in sport, there is tremendous risk in being a child, a youth, and an adolescent. Because if you're not playing sports, you're going to be climbing trees, going down the rails on a skateboard or a bicycle. You're going to be doing things that are dangerous. And the most severe traumatic brain injuries we see are from things with wheels, bicycles, skateboards, motorcycles, four-wheelers, and when you defy gravity, playground equipment, trampolines, etc. So keep in mind that team sports have tremendous benefits, which have already been talked about today. First and foremost, they're fun. Secondly, there's tremendous physical benefits for energy systems, movement patterns, bones, muscles. It keeps kids active, and they're more likely to exercise as adults if they played sports as kids. There's tremendous psychological benefits, self-esteem, learning how to win, learning how to lose, making friends of your teammates, lifelong friends, which we all probably have as we look back on our sports participation. And of course, then the benefits of decreasing risk of diseases like obesity, diabetes, sleep apnea, possibly even cancer. So we have to keep in mind that our objective is not to get rid of sports, but it's to make sports safer.
Thank you, Dr. Stewart. We'll turn now to Dr. Amy Custer. You've heard before, will be announced as the new clinical director of TRIA Sports Concussion Program, a clinical neuropsychologist. Tell us about the ways that you, multifaceted ways that you evaluate and treat concussion.
Yeah, so I'm going to come more from the clinical aspect of this, but just piggybacking off of what you said, Dr. Stewart, it really is, our goal is to make the game safer, right? And that's what we do really clinically too, of how we are assessing this injury now and how we are managing this and making sure in all different dimensions that the athlete is ready, is safe, and is able to go back to their sport. So there's been a lot of advances in how we look at this injury. It's not just a symptom scale, it's not just computerized neurocognitive testing, but it's really understanding who this athlete is before the injury occurs. And so research has really developed in the last 5-10 years, finding different risk factors for cases that would require active treatment or that might go down a protracted recovery. Younger athletes, female athletes, they are at risk for prolonged recovery. Individuals with migraines are set up for different types of concussions or symptom profiles per se. We also see that ocular motor problems, difficulties with using your eyes together, a family history or even a personal history of lazy eye, some of the binocular dysfunction that we see with ADHD or learning disability, that sets that athlete up for a very certain type of concussion that requires active treatment. One of the newer ones that's come out is car sickness. Having a history of car sickness prior to a head injury actually sets you up for a very specific type of dizziness or vestibular problem after this injury. And I think one of the most important things that have come out that not only do parents and coaches need to recognize this, but athletes need to recognize this next risk factor. And that risk factor is actually playing through symptoms. So an athlete that plays through symptoms is 9 times more likely to take 4 to 6 weeks to recover rather than the typical 10 to 14 days. That's a big deal. And these are typically the injuries that are less dramatic, that are subtle symptoms, perhaps. They're not passing out on the field. You might not see them stumble on the field. So it's really on that athlete to stand up and say, yeah, I don't think I'm right. And Dr. Heather Bergerson talked about this a little bit in the beginning panel of how the pendulum has swung. And there's been, from just getting your bell rung to now, it did swing, I think, a little too far. It's starting to balance. And, in the last couple of years, I've seen a lot of my athletes be more anxious about head injuries and maybe reporting symptoms, speaking up a little bit more. And I think in the last 6 months, I've actually seen it go a little bit the other way. I think athletes are fearful of speaking up. Maybe they don't want to admit that they have an injury they don't want to be held out of, and so they have a tendency to want to play through. We got to make sure that doesn't happen. But when we assess these injuries clinically and really are trying to determine how to best treat this very individualized injury, we need to know who they were before. We need to know what the immediate signs and symptoms were, the severity of the injury. But then we use a lot of different clinical tools on assessing this. And again, it's not just symptom scales. It's not computerized neurocognitive testing, although that is good. And those are very important pieces, but it's much more of a multidisciplinary approach. And it's looking at visual systems, it's looking at ocular motor movements, it's looking at balance, vestibular, and by vestibular I mean the athlete's ability to stabilize their vision, to interpret movement and motion, to integrate visual stimulus, all things that athletes need to do very well to be an athlete. But it's looking at that. It's also assessing cervicogenic involvement as possible contributors to dizziness or difficulties concentrating. We see symptoms come from a lot of different areas. Psychological aspects of this too. Anxiety can create a ton of symptoms that are very similar to concussion. So really making sure that we are assessing this fully and coming up with where the aberrant signal is coming from. If we can figure out what type of concussion or where's the aberrant signal, then we know our best point of intervention. And we've come up with a lot. There's still a lot of development going on, but there's active treatment approaches now. Gone are the days of dark rooms and rest. We're activating individuals safely, our athletes, within sometimes 72 hours of the injury now. And we're seeing better outcomes. We're gradually getting them back into school. We're having them on routine schedules instead of staying asleep all day. But we have active approaches of exertion therapy, vestibular therapy, vision therapy, ocular motor retraining, sports psychology. So it really is a team approach to making sure that this athlete is ready to go back to, if it be school or to get back on the field. It's not just simply being asymptomatic. And I think that, too, is an important piece where we can make this sport safer, making sure that athlete's ready to be on the field or the ice.
Thanks. I think we'll open up by picking up on a point you just raised, and that's the challenge of getting athletes on board and creating a culture of reporting. Culture is a word we've heard a lot today. I'm wondering if you could, if you want to jump in, any of you comment on how do you get buy-in from athletes? So things that we see are athletes who, not because they're liars, but because they want to play the next day or they want to play in the rest of the tournament, will come to you and you say, how do you feel? I feel fine, even though they don't feel fine. Or will, if they're taking a baseline test, deliberately try to score poorly. How do you address those issues and get athletes on board with you so that they're honest with you and open? What are strategies that you use?
Well, I think it starts with education. So we've learned even at the professional ranks that athletes now are respecting their brain more. They understand the potential consequences of what was mentioned here this morning, and that is returning to play too soon or denying symptoms. And I think the second part of that is coming up with objective diagnostic tests. And so it's very important to realize that concussion symptoms evolve over time. So yes, some athletes will deny the problem. Other athletes simply don't have symptoms until the next day. And I'll never forget removing a hockey player from a state tournament game evaluating with every tool we had. He was completely normal, no symptoms, let him play, scored a goal, took him out just because we were still worried, examined him after the game, still asymptomatic, passed every test. I got a call at 3 o'clock in the morning from his mother that she found him lying on the kitchen floor, screaming in pain, holding his head. I told her to call 911. I thought he had an intracranial bleed that we missed. Went to the emergency department, skull x-rays, CT, MRI, everything normal. By Sunday afternoon, his symptoms were gone. So we can't always diagnose a concussion at the point of care. And we can never predict severity or the duration of symptoms or time to return to play. So tongue in cheek, when a parent asks me, when can my son or daughter return to play after concussion? And I tell them sometime between a week and never. Because I honestly don't know. I've seen athletes symptomatic for years, permanently. So I think an objective diagnostic test, which doesn't rely on symptom reporting and doesn't necessarily rely on observing signs or neurologic problems, would be helpful. And whether that's a rapid number naming test like the King-Devic test, whether it's a fluid biomarker like testing somebody's saliva or a drop of blood for biomarkers, there's got to be a way, and that's why we have some real exciting research in these areas, which will help the healthcare providers do a better job of taking care of our athletes.
And I think we use our athletic trainers a ton for the education part of it, because that's so. We just had a study published where we asked, people, you wonder, you tell people something, but you wonder what they're really hearing. So we wanted to know, because we have a bunch of trainers out in our areas, high schools. We cover about 18 area high schools. And we do provide a lot of concussion education, but you wonder how much is getting through. And in this survey, one of the things that came across is only a third of people responded that a concussion was indeed a brain injury. I don't know what they thought it was, or whether they thought because there were no MRI changes, although we're getting sensitive there more now, but no X-ray changes, that it wasn't a brain injury. But I think if the culture of the team and the culture of the coach and the training staff, I think that if there's a culture of comfortableness with, hey, this is a serious business, we want to take care of you guys, we want to protect you guys, don't be afraid of, and really our goal is to get the person back safely as quick as possible. So if they know everybody's working for that goal, if they know the severity of what could happen, if we use our staff for the educational purposes, I think that culture is key to create comfortableness.
I agree with that completely. It's that culture. And I certainly think from an athletic trainer's perspective, we are seeing that shift, but there certainly still exists what I call a little bit of an old school mentality, and the coaches that'll say, don't go see the trainer, they're just going to hold you out. Yeah. The hide everything from your medical providers. Because they think we're the bad guy. I was once introduced at a team banquet as the person whose job it was to give coach bad news. And, so that's a challenging thing to overcome, but certainly to recognize that we're not the bad guy. We have a job to do, but we want to win just as much as you do. I mean, I have the same national championship rings as the coaches and the players from my days at the U. So, I mean, we want to win too. And our goal is really to get them back as quickly as possible, but we need to do that safely.
Mm-hmm. Great. We may have time for an audience question if there is one. Otherwise, I've got much, but I want to make sure. So I'll take the moderator's prerogative to ask maybe what will probably be our last question then, if there are none from the field. And it has to do with something we heard before, again, a theme for the day, asking questions and trying to get expertise. A real challenge is when someone doesn't have an athletic trainer on the sidelines or doesn't have, Mayo next door. They may not know what questions to ask or where to go, and they just hit Google because their kid. What sorts of questions should parents and youth organizations and coaches be asking of their medical team, various medical professionals, to know if, in fact, this person knows anything about concussions? Or what do you look for? How do you find?
Well, I think I would recommend the concussion recognition tool. So you may be familiar with the consensus conferences on concussion in sport. The most recent one was actually last fall in Berlin, Germany. And they came up with a tool which is not for medical providers, because we all realize, even though we'd love to have an athletic trainer at every event, it's not going to happen Graham Arena 4, Saturday morning at 9 o'clock in a Pee Wee hockey game in Rochester, Minnesota, when there's 5 games going on simultaneously. But the concussion recognition tool is for parents and players and officials and coaches to understand the red flags. If you see a red flag, that person goes to the emergency department. If you don't see one, you remove them from play. And then there's some very simple questions that have to do with orientation, symptoms, memory, that anybody can actually look at. And lastly, again, is this King-Divic test. If you have a baseline time it takes to read these numbers, anybody can administer it in less than 2 minutes. If the player takes longer to read it after a suspected concussion, they're out and they're referred to their healthcare provider. So I'd strongly recommend that you look at the concussion recognition tool, because we simply don't have healthcare providers at every sporting event throughout the United States.
They could just search for that and get that over the internet,
Yep.
right, Mike?
Yeah, it's public. Yeah,
So
that's
we've
great.
got, I think, just time for closing thoughts, and I leave it to you to offer us what you think. And I'd also encourage you to offer us resources, including your own Trio Mayo or others, just to go online and learn about our resources that are available. Do you want to?
Go ahead, start.
She's other. I mean, we also too, we have some like sideline cards and handouts that we provide for our coaches and other youth associations. So it's very similar to that concussion sideline tool to give them resources to be able to recognize, but really understanding those signs and symptoms. And again, I think somebody said this already, but when in doubt, sit them out. It's better to be safe than sorry, always. But yeah, our website, even some of the heads up information too is really great. They've got great sideline tools and things that you can have with you.
And heads up, CDC, the
Yes,
Center for
yes.
Disease Control, which is mentioned in the statute as well. So, great.
I think certainly if you're looking here locally within the Twin Cities, TRIA would be happy to be a resource for you. We have a multidisciplinary sport concussion program with physicians, Dr. Custer as our neuropsychologist, physical therapist, specialty trained in vestibular and exertional rehab, and then athletic trainers as a part of our program as well, and then other multi-specialties across our system when those are needed. And then with regard to athletic trainers or education for your association, education for your coaches and parents, we do a lot of that in the community, and we'd be happy to work with you or help you out in that area as well.
Mm-hmm. Yeah, and we as well at Mayo Clinic, we're in Rochester, but again, some of you may not know, we're actually downtown Minneapolis, right across from Target Center. It's called Mayo Clinic Square. So we just opened up another 15,000 square feet. So you know, the shields of Mayo there's 3 shields in Mayo Clinic in the insignia. They're research, practice, and education. So we try and validate all these things. So does it really work? You know, is this really valid? So we do the research that drives how we practice, and then we try and teach that best practice to others. So both at Rochester and Minneapolis, that's what we try and do with our athletes. For injury protection, foundational elements are so key. Just how, you know, getting them that good foundation, because a lot of sports is neuromotor patterning, and when you learn bad habits, it's really hard to get those out. You have to have that good pattern and over and over and over written. So it's better to kind of get that good pattern initially. So the good foundational elements are key. We talked about the movement patterns. We also have a saying, pain-free doesn't mean normal. I do a lot of research on ankles and ankle sprains. So we found that after an ankle sprain, even though you may feel better, you know, you see a lot of people with recurrent sprains, still persistent pain. Most common injury in sports is an ankle sprain. And I found that we actually found that the muscles contract differently after a sprain, and you have to train them to contract together again. So you may be okay for life, but you step off the curb, oh man, it gave way again. Or you're playing a game, oh man, it gave way again. So taking that next step, and really it's not just pain-free being normal, it's restoring all those components of stability and strength.
I guess my closing remarks get back to the culture of sport, and I think that we all have to work together to make sure that we don't lose sight of the fact that it should be fun, and we should try to work against professionalism and specialization for our young athletes. Parents are sometimes the worst offenders, so that comes through education. But I truly believe in the value of sport, and I used to ask my kids on the way to hockey tryouts every year, you sure you want to play hockey this year? Because I wanted them to know that it didn't matter to me. They were doing this because they chose to do it. And I could have been driving them to tuba lessons, and I would have been just as happy. But I think we have to make sure that we accentuate the positive, try to get rid of the negative, change the culture, and preserve these wonderful activities for our children.
Thank you so much. And I just want to say thank you to a number of other partners in the room. Minnesota has a real wealth of expertise in this area, more so than a lot of other states. And each of your institutions, as well as Project BrainSafe in St. Cloud, Hennepin County Medical Center, Institute of Athletic Medicine, University of Minnesota, Sanford Health, a lot of us are trying to get together and think about these things collectively and get that out into the community. And so I hope that this summit will lead to more partnerships, and I look forward to talking with you afterwards. Thanks, Tyree, and with that, I think we're done. Say thank you to our panel.